鏡湖醫院院長馬學章醫生，以及仁伯爵綜合醫院院長郝昌宇醫生為我哋主持，有請兩位。第一部分研討會嘅主講嘉賓有李英傑教授、黃偉新教授、葉慶龍教授以及係呂信邦教授。將以下時間交俾兩位主持人，唔該晒。
多謝司儀嚇。咁啊，聽頭先啊軒先生講啦嚇，今日天氣非常之凍，咁啊，但係都呢個會場咧都係充滿一個好熱烈嘅學習氣氛嚇，咁啊真係好開心。咁我今日都好高興啦，能夠同阿郝昌宇副局長同院長咧係同一台一齊去主持今次第一個 session 嚇。咁啊時間都緊迫，咁一陣咧我哋每一位講者完咗之後咧，我哋會俾大概2至3條嘅問題俾台下嘅觀眾去發問嚇。咁但係希望盡量係精簡啦嚇。咁啊，第一個講嘅嘉賓咧就係李英傑教授。咁啊，李英傑教授係香港中文大學腫瘤學系名譽臨床副教授，亦都係顧問醫生。佢今日咧係會同我哋講咧就係 Advances in the Management of Blood Cancer, New Drugs, New Approach。咁啊，我哋歡迎李教授。
聽唔聽到㗎後面？因為我聽到嘅。首先係多謝大會嘅邀請，唔該。咁多謝大會嘅邀請，係可以有機會同大家去分享一啲最新喺醫學，特別喺血液科裏邊、血液腫瘤裏邊一啲嘅新嘅信息。咁天氣好凍啦，咁但係呢個暖意洋洋，我都希望仲有喺1-2個禮拜之後就新嘅年頭，我都喺呢度恭祝大家身體健康，萬事勝意。我因為唔係好識翻譯做中文啊，所以我嗰個 PowerPoint 咧都係主要用英文為主，啲字都好 condense 好細嘅，可能你哋睇得唔清楚。好多資料，我希望盡量去講解下嚇。What I'm going to talk about is blood cancer. Blood is a dirty juice. On the one hand, it helps you, work, help you feel energetic. On the other hand, when it goes into problem, then we have a problem because blood can have cancer, and the cancer we have is not one disease. Blood cancer is really heterogeneous, big groups. Some can be very indolent, very friendly. On the other hand, some can be extremely bad, aggressive, and rapidly fatal. And with the improved understanding of new latest molecular oncology, we've now been able to find some new targets, new drugs that help us to fight against these blood cancer. And what I'm going to talk about today is some latest developments. Latest developments in like B-cell signaling pathway inhibitors, BCL2 inhibitors, proteasome inhibitors, and immunomodulatory drugs, and some new monoclonal antibodies and CAR T-cell therapy. It's a big topic. So what I intend to do is to give you snapshots of what we know, what happened in the last few years. Now, the first one I talk about is acute leukemia. Acute leukemia is one of the very, very difficult to treat disease. The disease usually aggressive. Without treatment, they all die. Now, the problem is that these diseases, now we have very intensive chemotherapy. But over the last 30 years, we have made very little progress in terms of therapy. In the last, the recent meeting in the state, we call it ASH, or American Society of Hematology annual meeting, there were two important practice change trials presented in the meeting, in the plenary section. One on the acute myeloid leukemia and the other one on acute lymphocytic leukemia. And for the interest of time, I will talk about the study presented on AML, or acute myeloid leukemia. Now, acute myeloid leukemia, as far as I'm concerned, there are only two types: the good AML and the bad AML. Bad AML, one of the bad AML is FLT3 AML. The FLT3 AML is an AML which harbors mutation on the FLT3 mutations. And patients with these leukemia, they respond to therapy. unfortunately, they will relapse. And once they relapse, they'll quickly die, no matter what you do, unless they have a chance to receive bone marrow transplant. And the treatment for acute myeloid leukemias in the last 30 years has not made much change. We usually will give patients very intensive induction chemotherapy using daunorubicin and RSA. And then once they achieve remission, then they will receive high-dose RSA intensification. And for those with matched bone marrow donor, we will then subject the patient to receive bone marrow transplant. And that's the best treatment for any AML patient, especially for the poor-risk patients. And this is a phase 3 international, double-blind international randomized trial just to see if a new drug adding to this protocol will help and make a difference. The drug the drug here is the midostaurin. This is a very interesting drug that targets onto the FLT3 mutations. And I'm sorry for the very condensed slide. I'm not sure you can see. What I'm trying to show you is that you look at the survival curve on the left-hand side. On the left-hand side, there is two curves. The first top one on the top is event-free survival. Basically, you see those patients receiving the new drug or experimental arm, they will have a better event-free survival. The red curve is the control arm. And if you look at the table on the left-hand side, you'll see that the median survival almost double or 3 times, because on the control arm it's about 26 months compared to the experimental arm, 74 months. So this is a big improvement in terms of survival. So the lessons we learned from this study is that by adding a new drug, you will make a big change on the outlook. This is not what we used to see in the last 30 years. In the last 30 years, we make change on the schedule, we add drugs. We were not able to make any new change. But these studies show a new observation. Yes, we can. We can make a difference on their future. The next disease I want to talk about is chronic lymphocytic leukemia. Now, chronic lymphocytic leukemia is slightly different from acute myeloid leukemia or acute leukemia. This is a disease relatively friendly because most of them will run an indolent course. Some can survive 3 years, 5 years, 7 years, or even 10 years without therapy. The problem is that they relapse. And so far, we don't know if we can cure the disease. This leukemia usually affects the older populations. And the median age of diagnosis is 72 years old. And the standard of care nowadays are essentially chemotherapy. And one of the most commonly used chemotherapy drugs we call fludarabine. The fludarabine-based chemotherapy is relatively effective because it gave you very high response rate and improvement on the progression-free survival. However, this is quite a toxic drug. For older individuals, they may not be able to tolerate the toxicities. So the alternative chemotherapy is to use bendamustine or together with rituximab, which is a monoclonal antibodies. And still, some patients cannot tolerate this protocol, then they would receive some oral drug, corambacil, which has been in the market for more than 40 years. But when we treat this chronic lymphocytic leukemia, we have problems. As I said before, most of these patients are older patients. They have problem taking toxic chemotherapy. Once they receive toxic chemotherapy, they have problem, they have infection, they have myelosuppression, and they die. So these so-called toxic cytotoxic chemotherapy are usually applicable to younger individuals. And also by giving fludarabine-based chemotherapy or corambacil chemotherapy for a long time, there is a risk of secondary cancer like leukemia. So what can we do? Now, recently we have some new drugs, novel drugs, trying to address some of these difficult issues. And in fact, we have new monoclonal antibodies like ofatumumab or obinutuzumab. And we also have new drugs called B-cell signaling pathway inhibitors, including the ibrutinib and idelalisib. And of course, the BCL2 inhibitors. And for the interest of time, I will just focus on the B-cell signaling pathway inhibitors. Now, the B-cell signaling pathway is a very interesting pathway. For all of us, we have lymphocyte. We have B lymphocyte. The B lymphocyte, when they appear on Earth, they will grow up, mature, and they die. And all these associated with this B cell or B cell signaling pathway. With the stimulation on the receptor on the top here, the B cell receptor here, it will have downstream signal that subsequently control the maturity, proliferations, and apoptosis. So the cell will eventually go old and die. But these pathways are also important in CLL or chronic lymphocytic leukemia, because in these pathways, some of the enzymes were known to be activated or overexpressed. For example, the BTK, Bruton tyrosine kinase, and the other PI3K delta. And because of these two enzymes are overexpressed, overactive within the tumor cells, people look for new way to treat the disease. Two drugs recently been developed. One is ibrutinib and the other one is idelalisib. Both of these drugs target on these enzymes and work very well for resistant refractory CLL. And both drugs been just approved in the US in 2014. Now, after the initial phase 1 study, this is the phase 1b2 study, multi-center study, and you can see this is a study on ibrutinib in a group of patients, chronic lymphocytic leukemia, highly resistant pool-X chronic lymphocytic leukemia. I want you to look at these on the left-hand side. The overall response rate is 71%. Now, remember, these are the group of patients who failed treatment already, and usually will expect that, well, I don't think the drug will work for you. But when they receive this new drug, 71% of them respond to therapy and they survive well. 75% of them will have progression-free, and about 83% of them will survive at about 26 months. And you look at the curve on the left-hand side, you see it's quite relatively quite long, and they survive long, the progression-free survival and the overall survival. So this is quite interesting and effective drugs based on this phase 1b2 trials. So after this, a phase 3 trial was performed. This is a very important trial because it's a direct comparison between ibrutinib versus and against a new monoclonal antibody ofatumumab. And what I'm trying to show you is that you look at the response rate, 42%. Compared to 4% of the new antibody is 10 times better in terms of response rate. And you look at the curve. Look at the big gap between the two curves. The top one is the progression-free survival for ibrutinib. So patients receiving ibrutinib, they will have much better progression-free survival as compared to the control at any time point. So you look at by the 12 months, you look at the overall survival, so 90% on the ibrutinib and 81% on the control arm. So this is very promising agent for patients who failed therapy. Now, how about new patients? Because these drugs are so effective now, then people try to move these drugs onto them as a first-line treatment. This is a study, a Resonate 3 study, just been presented last month in the ASH meeting. This is a phase 3 randomized trial comparing ibrutinib, which is an oral tablet, versus a very commonly used drug called corambasil. And in this, I want you to look at this here, the blue highlight here. These are the new CLL patients, yes. But the median age is 73. And most of them are older than 70 years old. And they have poor risk disease features, including advanced stage, complex cytogenetics, and also comorbidities. These are the difficult CLL patients we would be seeing in the clinic. But look at the survival curve. I think I can impress you with this curve on the left side, the big gap between the experimental arm, ibrutinib, and the control. So patients receiving ibrutinib, they do well, and they do well not initially, but for a long time. As the median follow-up of the study is 18 months, and they do well without problem. And the overall survival, by the first 6 months, there already a separation between the two, the experimental arm and the control arm. So the conclusion of this study is that if you gave the drug, ibrutinib to your new patient, even they're old, even they're sick, even they fail, they will do well because they will have at least 84% reduction in the risk of death and progression. So this is good news for CLL patients. So the paper was actually published on the same day when the author presented the paper in the ASH meeting in New England Journal of Medicine. This is the other drug I want to talk about, idelalisib. Again, these drugs are tested in patients with refractory relapse disease, and this is similar to the other trials that many of these patients are old patients, median age 70 years old, and with problem, comorbidities, impaired renal function, impaired bone marrow function, and so on. And then they receive just the oral tablet, idelalisib, compared to the control placebo. But of course, in this study, both also receive rituximab as part of the standard treatment. Now, the curve, the figures in the bottom, you see the big gap between the two. So again, these trials show us one important information is that by giving the new drug, targeted drugs, you will change their survival. The progression-free survival, you will move them from the bottom to the top one. And you look at the overall response rate, it's 13% versus 81%. Very different. And in the ASH meeting, there was an important trial published, presented. In this study is on, again also on refractory CLL patients, but both groups received different control, not only rituximab, but rituximab plus another drug called bendamustine. Now, these two, when they test, is a new drug versus placebo, and similar observations presented here, big gap between the two arms. So all I'm trying to tell you is that with these two new targeted drugs you gave them, they will have a new outcome. And last night I tried to delete this file because of the interest of time, but I put it back again because it's so important. For CLL patients, it is found that there's a protein called BCL2 protein. BCL2 protein is overexpressed in patient CLL. And this is a curse for the host, or it's a big curse for the patients, because this BCL2 protein make the cells immortalize, continue to grow without control. So what can we do is that scientists identify an inhibitor that can inhibit this BCL2 protein, then we might be able to make a big turn for the outlook of the patients. Now, the drug I'm talking about is APT199. 我好中意記呢個名，因為容易啲記佢個名啊。venetoclax. And phase 1 study published in New England Journal of Medicine showed that this drug, by giving to this refractory CLL patient, you will have 79% of response rate. And because of this, a important international phase 2 trial performed and presented in the ASH meeting. This group of patients started with a low dose, 20 milligram initially, and then gradually move up to full dose, 400 milligram. What happened is that by giving this drug, again, they have very good response because about 80%, or 79 to be exact, 79.4% of them will have good remission. This is a very fast, rapid, and deep remission. And some of them do achieve molecular remission as well. But the remission is durable. You look at the curve. The progression, the duration of response quite good. Most of them will remain in remission for more than 12 months. And because of this, on few days ago, this drug received FDA approval for the breakthrough designation. So I put it back again because it's really big news for us and also for the patients. Multiple myeloma. Multiple myeloma is a disease less common compared to chronic lymphocytic leukemia. This is again a disease usually affect the older patients. A typical patient will have marrow infiltration by the plasma cells, increased serum monoclonal proteins, renal failure, bone lytic lesions, and hypercalcemia. The standard of care for multiple myelomas nowadays transplant. For anyone, if they're young and fit enough, then we'll do them induction chemotherapy and then autologous stem cell transplant and then maintenance. This is standard of care for most patients. And for those who are not eligible for stem cell transplant for whatever reason, they still receive standard induction chemotherapy and then with maintenance. The drugs we use for induction include thalidomide, lenalidomide, bortezomib, and dexamethasone. Because of this new approach, the outlook of these patients has changed. In the past, multiple myeloma patients usually survive for about 2 years, 3 years, and then they disappear. But now with this effective induction chemotherapy and stem cell transplant, they survive much longer. Some survive 5 years, 6 years, 7 years, or even longer. So we have made a big change just because of the use of good effective induction chemotherapy and autologous stem cell transplant. Unfortunately, multiple myeloma remain to be an incurable disease because of relapse and resistance. Now, what approach? How can we do better? So people try to think can we do intensify the induction therapy? It is found that patients, when they have a good remission right from the start, the outlook is good, the prognosis is good. So can we give more drugs? Will 3 drugs, 4 drugs, or 10 drugs better than 1 drug? So in the last few years, more drugs been used or in combinations, and it's found that the response rate by giving 3 drugs apparently are better than 2 drugs. And that's one important phase 3 trial comparing these idea, 3 drugs versus 2 drugs. From here is a 3 drug, bortezomib, lenalidomide, and dexamethasone. And the control arms is lenalidomide and just dexamethasone. This is a phase 3 international randomized trial just to see if 3 drugs is better than 2 drugs. And you see that there is separation between the 2 curves. The blue on the top is to show you that 3 drugs is better than 2 drugs. Okay? So for new multiple myelomas, I think nowadays what we intend to do is just give the patient 3 drug combinations. Maybe the one we use here, bortezomib plus lenalidomide and dexamethasone, or any other combinations. But what if they relapse? This is not an uncommon situation. Multiple myeloma do relapse because they develop resistance. And this table shows you the new drugs that have been approved just in 2015. We have all different kinds of drugs like panobinostat, carfilzomib, isosomib, daratumumab, and alemtuzumab. These names are so difficult to remember. I can't remember them. Okay, but what you have to look is to focus is on the right hand side. These drugs are used for patients who fail 2 lines, 3 lines, or 4 lines. They are the drugs that help those most difficult patients. So if they relapse, I think my approach is like this. If they don't have stem cell transplant before, I will induce them and give them a chance of transplant. If they have transplant before and the relapse occurred long time from the last treatment, I will try the chemo one more time and consider second transplant. But of course, most of the time, they might just have the chemo and just last year. Then I have to think of alternative or the novel agents. The novel agent I mentioned just listed in this table. We have the proteasome inhibitors like the carfilzomib, isosomib, and the immunomodulatory drugs like pomalidomide or new monoclonal antibodies, daratumumab and alemtuzumab, and some other drugs. I will tell you more about the PI or proteasome inhibitors here. Proteasome is a very interesting Proteasome is very interesting. You call it enzyme within the cell. It's like a washer, a washing machine in the cell, or like a liver in the cell, because it helps to clear up the junk proteins in the cell. So we need a normal metabolism for the body as a whole, but in the cell we also need a good metabolism to regulate the junk proteins. And proteasome inhibitors is a drug that target on this proteasome. Once it binds to this proteasome, 就大件事啦. It causes a big chaos, a big fuss. It disrupts the normal cell cycle control, and it turns on a switch called apoptosis pathway. In other words, the cell will die. So if we are dealing a cancer cell that have very active, very naughty, unfriendly, and aggressive, we might send a proteasome inhibitor inside and turn on the switch. Hey, 收聲啦，唔好曳啦嚇。So this is what a proteasome inhibitor has been done and shown to be very effective for patients with multiple myeloma. And botulism was the first generation's PI, proteasome inhibitors. And now we have new drugs, carfilzomib, isosomib, and others. This is a very important trial, a phase 3 trial called ASPIRE trial. It's just to add carfilzomib into the standard backbone, lenalidomide and dexamethasone. And again, now you will be familiar with the curve. Always a gap, the experimental arm and the control arm. So by adding carfilzomib into the standard backbone, you make a change. You move them up. You improve the survival. Not only the response. Well, look at the response is 9% versus 32. Not very impressive. But they live longer. Okay? So this is just by adding a monoclonal proteasome inhibitors. You can extend the progression-free survival by almost 9 months. This is important by just adding one effective drugs. So it's also another proof that 3 drugs is better than 2 drugs. Again, last month, because a lot of news be presented in the ASH meeting, and this is a very interesting study because it's a placebo-controlled trials comparing the very new star called isosomib, which is one of the proteasome inhibitors. This is an oral form. It's not IV, not needles. This is all tablet. So the lenalidomide is all tablet. Dexamethasone is all tablet. So these 3 oral tablet regimen compared with placebo with the same backbone. And of course, this is on patients with relapsed multiple myeloma. What it shows is that there is also separation of the progression-free survival. You look at the response rate, sorry for the small table, okay? The response rate is about, overall response rate is about 78% for the experimental arm as compared to 71% in the control arm. Not big difference, okay? But if you look at the median duration of response, it's about 5 months, 15 months versus 20 months. And look at the median progression-free survival, 14 months versus 26 months. So by adding a once-weekly isosomib to this combination, you improve the progression-free survival by 35%. And these drugs just been approved by November 2015, 2 months ago. Monoclonal antibodies, 2 drugs, daratumumab and alutusumab. These are the 2 newly developed monoclonal antibodies that will bind to the specific target site. Alutusumab bind to the antigen called SLAM7, and the other one is anti-CD38. What it does is that it will elicit immune response to kill the cells, and both of them been approved recently for treatment of relapsed and refractory multiple myeloma. Now, alutusumab is a very interesting drug because it's a monoclonal antibody. Most of the side effects are just infusional side effects. And you look at this curve, again, you see difference between by the use of this alutusumab and the control. And there is about 30% reduction of the weeks of progression just by giving these new drugs. Daratumumab, Lancet, just published a few days ago, Lancet. This is daratumumab. I want to mention this one because this is a monotherapy in a hard-to-treat multiple myeloma. And in this study, the patient they enroll in the study are already failed 3 lines of therapy, very resistant, basically no hope at all. But by giving just single drug, you see the response. Overall response is about 29%. And the response is durable, okay? So I'm not sure how this drug will position. I'm sure soon this drug will come to first line eventually, maybe in 2 years' time. The final topic I want to talk about is CAR T-cell, chimeric antigen receptor T-cell therapy. I like CAR T-cell. I'm so excited to see CAR T-cell therapy. Not because of the race, because they have a license to kill. Now, CAR T-cell therapy is still experimental, still investigational, but it brings in a new hope to all B-cell neoplasm leukemias. In the summer of 2011, Carl Jung from Carl Jung from U of Pennsylvania, they performed a study of they used this therapy, CAR cell therapy, on a resistant relapsed CLL patient. Just a tiny dose of this CAR T cell, they see remission, 10 months. And CAR T cell, basically, what is CAR T cell? We collect the T cell from the patients, we modify, we program it, and we infuse to the patients. And by doing this, these CAR T cells will hunt down the B cell and then offload the bomb and kill the tumor. Very, very impressive. So what it does is that it modify the receptors on the CAR T cell and add two engines at the back, enhance and multiply the signal. So by the time they attach, they see the tumor cells, they will have an enhanced proliferation of T cell right on the spot to kill the tumor or leukemias. So because of this, it generated intense interest on the CAR T cell research. And in 2013, in the ASH meeting, a couple of studies presented. This is on CLL patients. What I want to tell you is that, look, these patients, about 60% of them have response. Okay? And we got complete remission just by giving this so-called T cell, modified T cell. For acute leukemia, refractory AL patient, same story. 14 of the 20 patients achieved remission. And the remission was durable, so durable that they can then proceed to allogeneic stem cell transplant. And for patients with, this is from Memorial Sloan Kettering, the other key player in this field. And for adult refractory relapsed AL, and even with the Philadelphia chromosome positive AL, again, they see response, and it works, and some of them were able to bridge to stem cell transplant. This is from NCI. The NCI also presented data for lymphomas, B-cell lymphomas, very resistant B-cell lymphoma, and again, they see good response. 12 of the 13 patients have over response, and 5 of them are complete remissions, okay? Now, I just want to show this table, very busy table. Just want to highlight this one. This lady has more than 10 lines of therapy, okay? And the other one has 13 lines of prior therapy. And you look at the response for the whole series, most of them do have remission and partial response. So this is a very interesting idea to help the patients to achieve good control of the disease. Now, I have to skip this slide. So this is the paper they published. This is a lymphoma patient. The tumors actually before therapy and after therapy disappear. This is so impressive just by giving the patient's own T cell. So I think that the CAR T cell therapy, the success of CAR T therapy demonstrates one important concept, is that our own immunity is so powerful, so effective in killing these refractory patients, where, I mean, in the old days, they don't have a hope at all. And these kind of T cells are now have extend to multiple myeloma. We identify a new, receptors on the multiple myeloma, the BCMA, and this is an NCI study presented last month. So even multiple myeloma, they find response. Different doses of CAR T cell, they shoot so patient. The study demonstrate effective response. Within 1 month, the multiple myeloma cell disappear in the bone marrow. So quite an impressive therapy, because this is for the first time we can use an immunotherapy or modified T cell to eradicate huge tumor burden in the body. Before I stop, I want to show this picture. This is a young girl, very brave girl, Emily Whiteheart. At the age of 6, she developed recurrent ALL after bone marrow transplant. At that time, the parents so desperate. They had no hope. They was very anxious. They don't know what to do. They approached University of Pennsylvania, and she was one of the very early patients who received CAR T cell therapy. And then this is the pictures. Okay, she survived. She did extremely well with the therapy. She returned to school and played with her dogs, okay? So the good science, all of these success start with science, okay? And also start with good collaboration between scientists, physicians, industry, and like what we're doing today. Thank you.
李教授可唔可以即係我哋俾時間少少 Q&A 好咁啊，李教授個 talk 非常之令人振奮啊！因為以前嗰啲好難醫嘅血嘅病嗰啲血啲 cancer 咧，而家都露咗好多曙光啊！咁我哋俾一個少少 Q&A 時間，有冇同事或者有冇觀眾想問一問李教授？我想問下你頭先嗰啲 for CLL 嗰啲藥咧，使唔使長期服用嘅嗰啲新藥？
好問題啊！藥廠好想㗎，藥廠好想長期服用啊！其實咧 for 其中一啲嗰兩個oral drug ibrutinib， 我本身即係一個 patient 用過啦最近。咁佢係一路食到佢係 progression 為止 ，idelalisib 都係，但係 for monoclonal antibodies 咧就唔係嘅。咁而家佢 approve 個 indication 即係都係 combine with coramidis 咁去用。咁所以我諗口服嗰兩隻咧就係暫時講係要長期食啦。
個價錢貴唔貴？
我又知道係好貴嘅，呢個好重要嘅 toxicity 嚟㗎 for the patient and for the government。
我有個問題又想問啊，啱啱先咧，即係喺你講題入邊咧，即係提到即係好多病咧，我呢個有聲啊，有咁咧就有80幾90% 嘅我哋叫 survival rate 嘅，或者係一個好嘅嗰個 life quality， 好似 Emily 我哋見到佢好病有幾歲嘅細路仔咁1年2年3年，我哋見到佢越嚟越靚，當然係非常之好。但係如果我哋講緊譬如有一隻新藥，呢隻新藥咧大概有20到30% 嘅 successful rate。或者係佢有20-30% 嘅 responsible rate to treatment。咁相反嚟講咧，即係話佢 overall 嘅 survival rate 咧，大概係講緊咧40到50% 到，即係類似呢啲咁嘅。而成個 treatment 咧，即係如果即係我哋大家都係澳門人、香港人都好明白。大概400-500萬蚊到可以一個 complete 到一個 treatment。咁喺呢啲咁嘅狀況下邊 ，new drugs 咧，我幾時都咁中意嘅，即係可以見到 Emily 咁好啊嘛，個個都好中意。但係如果講緊一個 case，我哋要用400到500萬，你點睇咧？
坦白講，我冇答案。我諗我哋即係從事醫療行業咧，我諗即係特別係從事呢個科研裏邊咧，我哋係好希望去揾更好、更有效嘅藥物去幫助我哋嘅病人。當然啦，我哋要平衡嗰個 relative 嘅 benefit and risk。但係成個社區去睇個醫療體系裏邊咧，佢要有一啲叫做 cost 或者 economic analysis 啊，到底係話俾我聽點樣 position 隻藥咧咁。我自己睇法有幾個層面睇嘅。第一就係如果個病人咧，即係去服用一個好嘅藥之後，佢係冇 problem 咧，可能有個成本咧係好貴。咁我哋好希望即係藥廠佢可以好快脆就減價啦，或者好快脆有啲新嘅藥，即係或者叫代用藥整出到嚟，咁樣可以平啲啦 patent 過。但係實際上，如果喺使用嗰個藥物裏邊啦，佢減少咗佢嗰啲嘅 failure， 減少咗佢嘅住院，減少咗佢期間嘅 problems。It's not only for 嗰個 patient 自己有 improvement in terms of quality of life and survival， 整個醫療裏邊咧，其實嗰個 costing 咧都係有改善嘅。當然個藥好貴啦，呢個我明白嘅。今日個醫療費用好貴嘅，咁呢個要交俾啲好叻嘅，即係啲財技嘅人，佢哋去諗辦法點樣去搞好嗰個醫療嗰個嘅 funding 嘅 situations。但係我相信係我覺得即係真係要向呢個方向發展咯。
OK，
唔該晒。
係，仲有冇問題？如果冇我哋袁生。
一個咧就冇佢咁高深嘅問題，好 basic。點解有血癌嘅咧？
呢個好高深問題嚟嘅啫。嗱，其實癌病好多種都好啦。咁先講血癌啦。我哋知道原因就知㗎啦，譬如輻射啊嗰啲嘢啦嚇，會引致到個變動。但係好多時癌病即係特別血癌咧，我哋好多大部分病人都揾唔到原因嘅。即係隨住年長嘅時候，個身體個細胞嘅新陳代謝，佢會出錯嘅。 佢周而復始咁，即係一個變兩個，兩個變四個咁樣嘅變法咧，你變咗好多千萬次 billions 咁多次咧，佢又出錯。once 一出錯之後咧，而佢本身個 counter check mechanism 又 fail 嘅話咧，咁佢就 out of control。咁我就答你就係我其實係我哋相信暫時揾唔到原因嘅，我哋只係知道點樣可以有病就早啲去處理佢，或者係處理咗佢咁解啫。係。
我哋個問題咧就話，即係人嘅身體嘅 immunity 對於血癌呢樣嘢嗰個即係點樣去互相即係呢個制衡嘅咧？譬如我哋嘅身體有 immune system， 都有呢個咁嘅東西產生嘅，咁最好就食鬼咗佢咁。係啱嘅。啦咁樣。
呢個係好好嘅諗法，事實就係咁啊！即係我哋好多即係在座當中，即係我諗有70後、80後、90後，但係有啲好似我呢啲好老嗰啲咧。咁我哋活到而家今日都托賴健在咧。好主要原因就係我哋除咗一個好嘅即係一個叫做正常健康嘅 healthy lifestyle 之外咧，其實個 immune system 係幫緊我好多。喺每日裏邊嗰啲好小病啊，所謂啊，小病裏邊我哋唔係咁多病。咁但係其實我身體裏邊嗰啲嘅所謂出錯咧，其實好多時我哋嘅 immune system 咧就已經係處理咗佢，已經處理咗佢。咁我 survive 到今時今日。咁當然啦，嗰個所謂 system 唔係 foolproof 啦。咁但係我以前咧係唔相信 immunotherapy 嘅。我成日覺得個 immune escape 個 tumors 咧係中國人嘅説叫道高一尺，魔高一丈。即係佢你幾咁 perfect 嘅 security system 咧，嗰啲賊咧會揾到窿啦，避咗你嘅，會戴個面具 mask 咗，等你個 immune system 咧係揾唔到佢。但係我啱啱 present 嘅 data 話俾我聽，唔係㗎。我哋好好咁去利用翻 immune system 裏邊佢嘅強項咧，我哋可以用翻即係以彼之道還施彼身係嘛？即係金庸嘅小説，咁可以應付去控制個癌病。我哋見到呢個方向，見到呢個曙光。而喺現實上，我哋喺呢幾年裏邊咧，好多嘅新嘅藥物，甚至係肺癌啊，其他嘢都係喺呢個方向着手，去透過啲藥物去改變個免疫系統咧，去對付癌細胞。所以答你就係可以有用嘅，我相信。
好，冇時間。最後一個問題啦最後一個問題同埋都希望短啲嚇。教授，這個專題剛好我有點興趣然後我想問一個問題，說你做白血病治療這麼久，那麼在你治過的患者當中，現在的生存率1年跟5年，1年、2年、5年的生存率大概多少？你治過的？
對不起，我不懂普通話，我可以說中文嗎？黃教授啱啱問個問題呢，就係即係到底我哋醫院裏邊呢，即係我哋醫治血癌嗰個嘅存活率係點樣？係咪？咁其實呢，真係好視乎你講緊乜嘢嘅血癌啦。如果係慢性嘅血癌，例如 chronic myeloid leukemia 啫，我哋同國際一樣嘅，大部分食緊人呢已經係唔需要。即係唔需要擔心，佢已經 survive 咗10 years 10年㗎啦。如果 chronic myeloid leukemias， 但係 acute leukemias 咧，特別係 ALL 咧，喺我哋同世界一樣，都係有好大嘅問題，因為佢哋會 relapse。咁我哋大部分嘅病人，我講緊係大約係 50% 嘅 long term。咁AML 嗰啲會好啲，係啦。
好啦，咁時間關係咁都多謝李教授係一個好詳盡嘅一個講述。咁由呢個。